And we'll go on with the topic for today. All right, today what we're going to talk about is the next major class of antibiotics that are used, and those are the ones that inhibit protein synthesis. Now, there are a few that affect nucleic acid biosynthesis, and we'll also discuss them. There's not two, there's just a few of those. And there's actually a couple that also affect one of the steps in intermediary metabolism that are used. And so we'll talk about them. But the big class here are those that inhibit protein synthesis. And before I get into the actual antibiotics, I just want to make a couple comments, general comments about the use of antibiotics and define a couple terms. Now, some of this Dr. Fox already mentioned, and I'll just go over those things very quickly, but I want to make a couple other points. As he pointed out, the whole issue with antibiotics is selectivity. And antibiotics, an ideal antibiotic should be very selective for the bacteria and not harm our cells. And in general, the higher the selectivity, the less toxicity that you're going to see. But you need to keep in mind that even highly selective antibiotics can have some toxicity associated with them. The penicillins are highly selective. They attack the cell wall biosynthesis. Well, we don't have cell walls, so obviously those antibiotics have no effect on our cells. But they still can be toxic. You already know from the immunology that antibiotics, you can develop type 1 hypersensitivity to penicillin. You can develop type 2 hypersensitivity to penicillin. So there can be some toxicity associated with even highly selective antibiotics. But in general, the higher the selectivity, the lower the toxicity is going to be. And of course, we can actually compute a number that relates or that lets us know how selective an antibiotic, and that's the therapeutic index, which is nothing else but the ratio of the toxic dose to the effective dose. And in the case of antibiotics, these therapeutic indices can be pretty high. I mean, it's not unusual to have therapeutic indices over 1,000, which means that the antibiotic is 1,000 times more effective than it is toxic. Now, Dr. Fox pointed out the two major classes, the bacteriostatic and the bactericidal antibiotics. And keep in mind, particularly when you're using a bacteriostatic antibiotic, you've got to treat long enough so that the host defenses have a way then of wiping out the residual infection. Because remember, these are not going to kill the bacteria. They're just going to inhibit their growth. So you're relying on the immune system. And quite frankly, even with bactericidal antibiotics, you still rely on the immune system to wipe out the residual infection, because no antibiotic is going to kill 100% of the bacteria. So we always rely on host defenses to get rid of the residual bacteria. Now, obviously, if you had a choice between these two types of antibiotics, you would prefer to use a bactericidal antibiotic. Because you're going to actually be killing the bacteria in this case. But there are some instances where, in fact, you will select a bacteriostatic antibiotic over a bactericidal. So, for example, the therapeutic index may be different. If you have a high therapeutic index for a bacteriostatic antibiotic, you might want to use that one instead of a bactericidal antibiotic. Resistance may have developed to the bactericidal antibiotic, and you have no choice. You have to go to bacteriostatic antibiotics. And there are some instances, particularly when the disease is mediated by a protein toxin, where you're going to use a bacteriostatic protein synthesis inhibitor. And the reason for this is that if you use a bactericidal antibiotic, in this case when the disease is toxin mediated, it takes some time before you kill the bacteria with the antibiotic. And in that time, these bacteria are going to continue to be making that toxin and secreting the toxin, and it's the toxin that's mediating the disease. It's preferable to use a protein synthesis inhibitor, even though most of them, as you're going to see, turn out to be bacteriostatic, because you immediately can shut off the synthesis of that toxin which is causing the disease. So there are some times where you would use a static antibiotic rather than a cidal one. And of course, Dr. Fox mentioned antibiotic susceptibility. He introduced the term the minimal inhibitory concentration, which is the concentration that results in the inhibition of visible growth of the bacteria. There is another term that you may come across, and that's bactericidal, or minimal bactericidal concentration, or MBC. it is the concentration that kills 99.9% of the bacteria, that by definition. Notice it's not 100%. We're killing off 99.9% of the bacteria. That is considered the minimal bactericidal concentration. This term, you may come across it, but again, when you talk about these things, there's a certain degree of sloppiness comes into the vernacular. And we typically will just say the MIC, even though we're talking about a bactericidal antibiotic. So it's not uncommon for to use this term to refer to all antibiotics, the inhibitory concentration of all antibiotics, whether they be static or cidal. And of course, the way you determine that MIC is to simply take make a series of dilutions of the antibiotic, inoculate with bacteria, and then look which ones have turbidity. It doesn't come out. I should have made this a little bit darker, but these still have some turbidity. This doesn't. So this is the minimal concentration that has no visible growth. So the MIC would be 2 micrograms per mil. And as Dr. Fox pointed out, typically that's not done in most labs because it takes some time to do it that way. The easier way is to do the disc diffusion, also known as the Kirby-Bauer test. Now, the other thing you need to keep in mind, though, in these Kirby-Bauer tests, it's not as simple as just looking and measuring the diameter of that ring, because the diameter of that ring of inhibition, of growth, really depends on a number of things. It depends upon the organism that you're talking about. It depends upon the sensitivity of that organism to the antibiotic. It also, however, depends upon the solubility of the antibiotic, the rate of diffusion of the antibiotic. So a number of things can influence that. So you can't simply just look at this and say that this one is more sensitive to tetracycline than it is to ampicillin. It's not that simple. What's generally done in the lab is they do, of course, measure that diameter, that ring. And then there are tables that relate the diameter of the ring to sensitivity or resistance based on the particular isolate. So, for example, if the lab isolates a member of the family Enterobacteriaceae, and you're using an ampicillin disc with 10 micrograms of the antibiotic incorporated into that disc, then in order for a cell to be considered to be resistant, the ring of diameter would have to be 11 millimeters or less. And it would be considered sensitive if the diameter of that ring was greater than 14 centimeters. So it varies. If you look at a different species, like the Antibiotics-I, now in order to be resistant, it's considered resistant if it's greater than 60, equal to or greater than 16 millimeters in diameter. And these tables also give you an approximate MIC. These are approximations as to what the MIC actually is. So what the lab is going to do is actually measure the rings of the diameter, come to these tables, and then report out to you that yes, this is sensitive or this is resistant. Okay, it is not uncommon when prescribing antibiotics to use combination therapy, and there's a number of reasons why you would use combinations of antibiotics. One is to prevent the emergence of resistant strains. By using combinations, you really cut down on the probability that resistance is going to occur. Typically, the resistance occurs, say, 1 out of 1 million cells. You may be resistant to a bacterium. If you use 2 antibiotics, the probability of finding a cell that is resistant to both of those antibiotics is actually the product of those probabilities, or 1 out of every 10 to the 12. So you seriously cut down the likelihood of detecting or selecting out resistant mutants. Another reason why you use combination therapy is for temporary treatment. You're not going to wait. You already know now that it's going to take several days before the lab is going to be able to grow that bacteria, identify which bacteria it is, and then do antibiotic susceptibility testing for you. So you're not going to get that information out immediately. Now, there are some newer equipment that can do these things a lot faster. They don't have to wait for complete growth, but it's not going to be something immediate, and so you're not going to wait. If you've got a patient that you suspect has a bacterial infection, you're not going to wait. You're going to treat, and oftentimes you treat with combinations of antibiotics, things that you know should cover most of the bacteria that you're likely to be infecting that patient. The other option you have here, rather than using combinations, you can also use a broad spectrum antibiotic, one that covers a whole series of different bacteria. So those are your options. But another reason why combination therapy is used to take advantage of synergism with antibiotics. And the classic example is the penicillins and the aminoglycosides. What happens here, the reason these things synergize is that the aminoglycosides actually they're pretty good antibiotics, but they don't get into the bacterial cells very well. And so by using a combination of a penicillin or any of the beta-lactam antibiotics for that matter, with the aminoglycosides, what happens is the penicillins begin to disrupt cell wall biosynthesis, so you get the bacterial envelope is weakened. That allows the aminoglycosides to get into the cells a lot easier, and they work in concert with each other. But you need to be careful because not all combinations are good. You would never want to use a penicillin or any beta-lactam antibiotic for that matter together with the bacteriostatic antibiotic. Why is that? Why is that a bad combination? A penicillin or a beta-lactam antibiotic with a bacteriostatic antibiotic. Why wouldn't you want to do that? How do penicillins work? They inhibit cross-linking of the cells, right? So in the cell wall, right? When is the cell wall? When do you think those antibiotics are going to work on a bacterial cell? When they're growing, right? Unless they're growing, there's no reason to be synthesizing cell wall. So the cell's not going to be making cell wall when it's not growing. So they have to be growing for these things to work. Well, so if you throw a penicillin in together with a bacteriostatic antibiotic, you've essentially inactivated the penicillin because they're not growing anymore, and so the penicillin won't have any effect. So not all combinations are necessarily good. You have to watch out what combinations are used. And then finally, just want to define a couple terms. The term antibiotic, actually, strictly speaking, it refers to naturally occurring products. Typically, these things come from fungi, and the fungi are producing these things to kill bacteria, and that's the way they compete with the bacteria for foodstuffs in their environment. So these are all naturally occurring materials. The term chemotherapeutic agent, in contrast, is something that is made in the lab and has antibacterial activity. The problem is that the distinction between these terms is sort of blurred because nowadays, while most of the antibiotics that we use are based upon something that ultimately occurred in nature, in fact, they've been modified quite a bit in the lab. Dr. Fox pointed out there are all these different side chains that get put on these things. That's all done chemically in the lab. Most of our antibiotics are not made now by the fungi. They're actually made synthetically in the lab. So what do you call them then? Are they antibiotics? Are they chemotherapeutic agents? People have suggested to use the term antimicrobial as a general term that would cover both of these things. But again, the nomenclature becomes a little bit sloppy. Most people just say antibiotics, and whether they're referring to an antibiotic that was actually made by a living organism or a chemotherapeutic agent. So we use the term very, very loosely, and that's the way we'll use it throughout this class as well. Okay, so the group of antibiotics that inhibit protein synthesis. Now, just as with the cell wall and synthesis inhibitors, you can't understand, or you can't appreciate how these things work unless you know protein synthesis. Now, I know you've all had protein synthesis, and I'm sure that if I asked any one of you to come up here and review protein synthesis, that you can do it. And maybe I ought to do that this year. I keep saying I should do that. Does anybody want to volunteer? All right, I'm going to do a very, very quick review of protein synthesis for you, and then so that we can talk about where these antibiotics actually work. And we'll begin with initiation of protein synthesis. And we'll be talking about bacteria. Now, you probably learned it with eukaryotic ribosomes, which are 40, the subunits are 40 and 60S. Bacteria, of course, have the 30 and 50S subunits. So we're going to talk in the terms of bacteria. So the initiation of protein synthesis occurs with the association of some initiation factors in GTP with the 30S ribosome. The next step is to add the messenger RNA and the initiator tRNA. And if you remember back from I think the first day of immunology, we talked about the fact that bacteria have all their messages, all their proteins start with FMET. So here's the initiator tRNA, is formyl methionine tRNA. And the messenger RNA, the FMET, associates with the ribosome and with the 30S ribosome to produce the 30S initiation complex. Then the 50S subunit is added to produce the 70S initiation complex. In that process, that's an energy-dependent process, and the GTP is hydrolyzed to GDP, and the initiation factors are released. And we end up then with an initiation complex, 70S initiation complex, with the initiator tRNA, the formyl methionine tRNA, situated in the P site of the ribosome. Now, there are a number of antibiotics that block this step, this process. One of them is spectinomycin, and it's going to block up here. And we have the aminoglycosides, which block over here. And we'll talk more specifically when we talk about the individual antibiotics, what they're actually doing at those places. Okay? All right, the next step in protein synthesis is elongation. And so we start with, here's our 70S initiation complex. And in the case of bacteria, there are some elongation factors. You probably learned them by different names, but in bacteria, the initiation factor, or the elongation factors, are referred to as TU and TS. And these form a complex in the cell. And what happens with this complex, the complex of TU and TS then picks up GTP and some aminoacyl tRNA. And these factors, these elongation factors, actually bind any of the aminoacylated tRNAs. So some aminoacylated tRNA plus GTP associates with that. TS is released, and we have then the TU complexed with the aminoacyl tRNA and GTP, and it is this elongation factor that delivers the aminoacyl tRNA into the A site of the ribosome. Now, this is, as I said, TU, of course, picks up any aminoacyl tRNA. It's not specific. What determines the specificity is the codon in the message. Only the tRNA that has an anticodon that can read that codon will actually insert into that A site. Okay? And in that process, the GTP is hydrolyzed, and then TS acts to dissociate the TU from the GTP to produce the complex again, and then you repeat this process. Okay? All right, so that's the first step in elongation. The next step is the peptidyl transferase reaction, where the amino acid in the P site is transferred over to the amino acid in the A site, and the peptide bond is formed. That is peptidyl transferase reaction. And then the third step in elongation is translocation. And again, this requires an elongation factor. In this case, it's elongation factor G. And a complex of elongation factor G and GTP then drives this reaction. This is an energy-dependent reaction. And in translocation, the tRNA that was in the P site is released. The tRNA that is in the A site gets moved over into the P site. And the ribosome moves over one codon. GTP is hydrolyzed, and then we end up with a GDP complex, and that has got to be dissociated. It dissociates, and then GTP is allowed to reassociate with G, and then this process continues. All right, so that's the translocation process. Once we reach here, this is analogous to this, except it's one amino acid longer, and so this process just continues over and over again as the message is read. Okay, now and there are some antibiotics that block elongation. The tetracyclines are going to block up here. Chloramphenicol is going to block here. Erythromycin and other macrolide antibiotics, this is a group of antibiotics called the macrolides, they block here. And then there's an antibiotic called fusidic acid that blocks there. All right, again, and we'll talk more specifically about what they do when we talk about the individual antibiotics. So here's a little movie about the thing. Here's the initiation process, the 30S associated with the ribosome and the FMET tRNA. Then the 50S is going to bind. Then we enter into elongation, where the next amino acid comes in. Peptide bond formation. Translocation is going to occur. next amino acid, and so on down the line. Okay. So then let's look at the individual antibiotics. As far as the protein synthesis inhibitors are concerned, they are mostly bacteriostatic antibiotics. There's actually one exception to that, and that is the aminoglycosides. But other than aminoglycosides, all the protein synthesis inhibitors are bacteriostatic. Okay? And of course, the differences, the basis of selectivity is the differences between our ribosomes and bacterial ribosomes. But keep in mind that there's going to be, inherently, there's more toxicity going to be associated with these antibiotics than there are, say, with the penicillins or the beta-lactam antibiotics. Because our ribosomes still have to carry out the same functions. Many times these things can have some effect on our ribosomes. But in addition, remember, we also have 70S ribosomes. We have bacterial-type ribosomes. Where? In the mitochondria, okay? So inherently, these antibiotics are going to have more toxicity than will the penicillins or the cephalosporins and those. All right. The way I've organized these things, we'll look at those, the antibiotics as they use as their target to different ribosomes. So we'll talk about those antibiotics that have as their target the 30S ribosome, okay? And the first one are the aminoglycosides. And again, this is the exception. These are the bactericidal antibiotics, okay, of the protein synthesis. All the rest of them, or the protein synthesis ones that we'll discuss, are bacteriostatic. Now, there are a number of antibiotics in this group, the aminoglycosides. I don't expect you to memorize all these names at this time. What I've done is I've underlined or highlighted or boldfaced, I think, in your handout, which antibiotic we're going to use as the prototype for this class of antibiotics. Okay, so our prototype will be streptomycin. So just keep in mind, streptomycin is an aminoglycoside, but you don't have to remember the rest of those. Okay, so how do these things work? The aminoglycosides bind irreversibly to that 30S ribosomal subunit, and what they do is they freeze the 30S initiation complex so that so you can't make the 70S complex. In other words, the 50S complex, 50S ribosomal subunit can't bind, all right? That's their primary mode of action. They freeze the 30S initiation complex. But they do have some other activities that are not insignificant. This is blocking, obviously, initiation. Well, what happens if protein synthesis is already going on and you're in the elongation phase of protein synthesis? Well, these antibiotics also have some effect on that. And what they do is they slow down elongation. But more importantly, what they do is they induce a lot of misreading of the message. So you misread the message, and wrong amino acids are put in the presence of the aminoglycosides. And the way they do this is they bind actually to the 16S ribosomal RNA that is a component of that 30S ribosomal subunit. And what they do is they increase the affinity of the A site for tRNA, regardless of what the codon-anticodon involved. Okay, so you'll have a codon for one amino acid, but because there's a high affinity or higher affinity for tRNA, any old tRNA can go in and insert into that A site. And that's why they cause this misreading, all right? In addition, these antibiotics can destabilize bacterial membranes. And it's thought that the reason that these antibiotics are bactericidal, whereas other protein synthesis inhibitors are bacteriostatic, is because of these other functions, because it can cause misreading, because it can destabilize bacterial membranes. That's why these antibiotics turn out to be bactericidal. Okay, so here's just the movie showing what will happen with in the misreading case. So we're going through initiation, 50S ribosome comes in. Now this codon supposedly means a certain thing, but in the presence of the antibiotic, there's a misreading of the codon because of the higher affinity of the antibiotic. So the wrong amino acid is going to be inserted at this point. Peptide bond formation goes on, and you end up with a lot of errors, a lot of bad proteins being made because they just get the wrong amino acids being put in. And it can cause misreading of the next codon and so on. All right. So that's their mode of action as far as their spectrum of activity. Now, as I go through these antibiotics, we're going to talk about their mode of action, spectrum of activity, their resistance patterns. In the case of the spectrum of activity, again, I don't expect you to remember all of these things, because whether or not they're used here for gram-positives or gram-negatives. At this point, when you get into the clinical bacteriology and you talk about the individual organisms, it's at that time, if there is an antibiotic of choice that's used for the treatment of those things, you'll worry about them at that point, not at this point. With a couple exceptions. Those that I've indicated here in blue, and I think in the handout, again, I either underlined them or bold-faced them. Those are the ones that I want you to remember. So in the case of the aminoglycosides, keep in mind these are not useful with any anaerobic infections. And the reason is that oxygen is actually required for uptake of these antibiotics. In the anaerobes, of course, the oxygen is not available, and so you can't use these for the treatment of anaerobic. You also cannot use these antibiotics for the treatment of intracellular bacteria. And again, it's for the same reason, basically. And aminoglycosides don't get into our cells very well. And so if you've got an intracellular bacterial infection, if you can't get the antibiotic into the bacteria, it's going to be ineffective. So no, not for anaerobes, not for intracellular bacteria. Resistance is common. In fact, this is going to be repeated, as you probably already know. Virtually every antibiotic resistance is a problem. And this is the one class of antibiotics that you can use in synergy with the beta-lactams. And again, because it's bactericidal, not bacteriostatic. Okay, the next antibiotic is a group of the tetracyclines. And again, there's a number of different things. Most of them have this cycline suffix added. So tetracycline is our prototype for this antibiotic. And again, if I neglect to say, keep in mind that all the rest of these are going to be static antibiotics. So what the tetracyclines do is they bind to the 30S ribosome, but they inhibit the binding of the amino-acyl tRNA to that acceptor site. So in the presence of tetracycline, that TU elongation factor can't insert the amino-acyl tRNA into the A site of the ribosome. Okay. Now this is a broad spectrum antibiotic. Again, in blue, these are the ones that I just want you to keep in mind. It's a very broad spectrum antibiotic, and so it's used a lot in its initial treatment when you don't know what you're dealing with. It's also going to be useful against, this is one of those that can be used for intracellular bacteria, since the aminoglycosides cannot. Resistance is a problem. Now, this one you have to worry about. These antibiotics, the tetracyclines, can have some adverse effects. One of them these are very broad spectrum antibiotics. They do a great job in killing your normal flora as well. And if you remember back to the immunology, I pointed out that the normal flora plays an important role of protecting us from infection with pathogens, because the pathogen has got to compete with the normal flora for colonization of the tissues. When you wipe out the normal flora with a broad spectrum antibiotic like a tetracycline, the patients are more susceptible to coming down with secondary infections with pathogens. So this is one problem. The other major problem with these is that these things, the tetracyclines, stain and impair the development of bones and teeth. So these antibiotics are not used in children, right? Because the teeth will actually turn yellow, and then you can interfere with bone development. Okay, so these are not used in children. Okay, the third antibiotic that works at the 30S ribosomal subunit is spectinomycin, and spectinomycin interferes with the association of the messenger RNA with the 30S ribosome. So you cannot form the 30S initiation complex. The messenger RNA can't bind. Now, this antibiotic actually, structurally, if you look at the structures, is very, very similar to the aminoglycoside antibiotics. But yet it is bacteriostatic, whereas the aminoglycosides were bactericidal. And the reason, again, it's thought is because this one, while it affects initiation of protein synthesis, it doesn't have those secondary functions. It doesn't cause misreading. It doesn't destabilize bacterial membranes. And so it is a bacteriostatic. In addition, it is a reversible, it binds reversibly to the 30S ribosomes, where the aminoglycosides bind irreversibly to that 30S ribosomal subunit. The spectrum of activity, has a much more limited use. It's used primarily in the treatment of penicillin-resistant Neisseria gonorrhea. The method of choice for treatment of gonorrhea is going to be penicillin, but in cases where there's resistance to penicillin, then spectinomycin is an alternative antibiotic that can be used. At least in the Neisseria, this has not been a problem, but it's a consequence of the fact that it's not used. The first line is going to be penicillin. If this stuff is going to be used more and more and more, there's no doubt that resistance will also develop to this antibiotic as well. All right. Those are the antibiotics that affect the 30S ribosome or target the 30S ribosomal subunit. There are a group that also target the 50S ribosomal subunit. Chloramphenicol, lincomycin, and clindamycin. And our prototype will be chloramphenicol. And what these antibiotics do, they bind to the 50S ribosome and inhibit the peptidyl transferase activity. The peptide bond can't form. These are, chloramphenicol is actually, again, one of these very broad spectrum antibiotics. The other antibiotics have a more limited range. Again, resistance is common, but even though chloramphenicol is a good broad range antibiotic, again, it's not used all that much. It's only used in very serious infections, and it's because of the toxicity of this antibiotic. It causes bone marrow suppression, so it's not one that's used as your first line, and it's used in serious infections where it may be life-threatening, for example, in bacterial meningitis, where you have to treat very quickly, and you want to make sure that you use a good antibiotic. So it's not one that's going to be used commonly. Okay, the macrolides. Again, a whole series of them. Erythromycin will be our prototype example of the macrolide antibiotics. And what these do is they inhibit translocation. They're used in a number of gram-positive bacteria. Mycoplasma, I'll be giving a lecture on the mycoplasma. This is the antibiotic of choice in the mycoplasma and also in the Legionella. And again, resistance is common. All these any antibiotic that is developed, basically, as it's being used, will, no question, result in resistance developing. It's only a question of when, not if. All right, so here's a little movie on erythromycin's action. Initiation of 50S complex. Elongation proceeds normally. The tRNA is delivered to the A site. Peptide bond formation occurs normally. And then we go into translocation. And in the presence of the erythromycin, which is going to come there, or the macrolides in general, translocation is blocked. We lose that. You just cannot add any more amino acids on. And you try, but it just keeps dissociating, and you don't get elongation going on. Okay? Right. Those are the antibiotics that target the 50S ribosomal subunit. There is one antibiotic that targets one of the elongation factors. Okay? And of course, obviously, the selectivity is the fact that our elongation factors differ from the bacterial elongation factors. And that antibiotic is fusidic acid. And what fusidic acid does is it binds to elongation factor G. That's the one that's involved in translocation. And it actually, what it does is by binding to elongation factor G, it blocks the dissociation of the GDP from that factor G. And so what happens is all of elongation factor G is complex with GDP. It can't dissociate, so it cannot reassociate with new GTP, and eventually use up all the factor G. Protein synthesis comes to a stop. Now, it's not going to be right away because you have to use up, basically tie up all that elongation factor G before it's going to actually inhibit. A spectrum of activity primarily in gram-positive cocci infection. Okay. Those are all the protein synthesis inhibitors. Some target the 30S, some target the 50S, and one targets the elongation factor G. There are a few antibiotics that target nucleic acid biosynthesis, and we'll look at the RNA inhibitors first, and obviously selectivities because our RNA polymerases are different than the bacterial RNA polymerases. All right, there's a group of antibiotics. Our prototype will be rifampin. All of these antibiotics have this RIFA prefix abbreviation. So these are all rifamycin, rifampicin, rifampin. These are bactericidal antibiotics now. We're out of the protein synthesis inhibitors. And what these antibiotics do is they bind to the DNA-dependent RNA polymerase, the RNA polymerase that makes messages. All right? And what it does is it blocks the initiation of transcription. It does not have any effect on transcription that is already initiated. So if an RNA polymerase has already initiated transcription of a gene, that will continue in the presence of these antibiotics. But no new messages will be able to be made because it's blocking the initiation stage. Now, these are actually pretty broad spectrum antibiotics. They're quite effective against a lot of bacteria, but they're really not used all that much. The primary place where it's used is in the treatment of tuberculosis. And the reason that these are not used very widely, even though they are very good broad spectrum of antibiotics, is that resistance to these antibiotics develops very, very rapidly. For some reason, RNA polymerase can tolerate the mutations that occur in that to become resistant to this antibiotic and not have any serious effect on transcription. So resistance develops very, very quickly to these antibiotics. And so when they are used in the treatment of tuberculosis, they're used in combination therapy. And Dr. Fox already pointed out when he talked about some of the antibiotics used in treatment of tuberculosis that they're always combinations of antibodies. This is one that's used in combination with other, for example, the isoniazid and things like that. And that's it for RNA synthesis inhibitors. There's one class of DNA synthesis inhibitors. And those are the quinolone antibiotics. These are also bactericidal antibiotics. The first antibiotic in this was nalidixic acid, and the next generation was this ciprofloxacin, and a lot of these have this oxacin suffix, okay? So these are the quinolone antibiotics. And what these do is these antibiotics bind to the A subunit of DNA gyrase. Now, DNA gyrase is a member of this class of enzymes called the topoisomerases. You'll remember back from your biochemistry, DNA is highly supercoiled. In order to replicate that DNA, you've got to release those supercoils, replicate the DNA, and then introduce those supercoils back into the DNA in order so that it is packaged properly. DNA gyrase is one of those enzymes that does that, okay? And by the quinolones basically bind to the alpha subunit of the DNA gyrase and inhibit unwinding and of the supercoils and then rewinding. So the bacteria can't replicate its DNA, basically. Again, its spectrum of activity, primarily gram-positive cocci, and these are used actually a lot in urinary tract infections because the pharmacokinetics are such that they get into the urinary tract quite effectively, and so that's where they're going to be most commonly used. The resistance to nalidixic acid is there. It was the first one that was being used, and when we switched over to ciprofloxacin, now resistance is developing to that one as well. Okay, that's it for the nucleic acid inhibitors. There are a few antibiotics that actually inhibit one step in intermediary metabolism. And those are the ones we want to discuss next. And all of these antibiotics that fall into this class are actually inhibitors of folic acid biosynthesis. So what's the basis of selectivity? Why are these antibiotics useful? Bacteria make folic acid, and ultimately what they're trying to make is the tetrahydrofolic acid. They make that from products of intermediary metabolism, and we'll look at the pathway in a second. So they take products or substrates from intermediary metabolism and convert it to tetrahydrofolic acid. Right? Now, we also need tetrahydrofolic acid, but we don't make it from our intermediates in intermediary metabolism. We require in our diet preformed folic acid. It's a required vitamin for us. So what we do is we take the preformed folic acid from our diet and we convert folic acid to tetrahydrofolic acid. Bacteria do it through that pathway where they synthesize it. But more than that, bacteria actually cannot use preformed folic acid. So even if you take a bacterium and put it in a sea of folic acid, it cannot use the folic acid. It always makes its tetrahydrofolate through intermediary metabolism substrates, okay? And so that's why these antibiotics are selective for bacteria. And so let's look at that pathway. Now what that pathway does, this is a step in intermediary metabolism where paraminobenzoic acid is produced, okay? That paraminobenzoic acid then becomes the substrate for tetrahydrofolate synthesis. So paraminobenzoic acid and pteridine, the enzyme pteridine synthase produces dihydrotoroic acid. That is converted to dihydrofolic acid by dihydrofolate synthase, and then the dihydrofolic acid is converted to tetrahydrofolic acid by dihydrofolic reductase. Right, and this is the pathway that bacteria uses. And of course, that tetrahydrofolic acid, again, if you remember back from your biochemistry, that is a methyl donor. The methyl group on thymidine comes from tetrahydrofolic acid. Some of the carbons atoms in the purines come from tetrahydrofolic acid as a methyl donor. The methyl group on methionine comes from tetrahydrofolic acid. So if you cannot make tetrahydrofolic acid, then you can't make thymidine, you can't make purine, so DNA synthesis is going to be affected. You can't make methionine. Okay? And so there are some antibiotics that work on this pathway. The sulfonamides work up here, and trimethoprim works down here. Okay? Again, we'll talk about what they do. All right, so start with the sulfonamides. The sulfonamides are the sulfones, the sulfa drugs. These are bacteriostatic antibiotics. And what they do, the sulfa drugs, or the sulfonamides, these are actually structural analogs of the paraminobenzoic acid, that first substrate in the pathway. This is a structural analog. And so they competitively compete with the paraminobenzoic acid for that, inhibit the formation of the dihydrotoroic acid. All right? But this is a competitive inhibition, so that if there's a lot of paraminobenzoic acid on, these antibiotics are not going to be effective. Okay? Again, these have a broad range of activity, but again, there's a place where they're primarily used in urinary tract infections and in nocardial infections. Resistance is very common to these antibiotics. Because these are competitive inhibitors, and because resistance develops to these things, again, this one is used in combination therapy. When these sulfa drugs are used, they're used in combination with trimethoprim. Now, trimethoprim, if you remember from a couple slides ago, also affects this same pathway. And the idea is you really want to shut off this pathway, so you use two antibiotics to very effectively block the pathway. If you use the sulfa drugs alone, there's a competitive inhibitors. They're not going to block it completely, or may not block it completely. So you throw in another antibiotic like trimethoprim to really ensure that you shut down this pathway. And obviously, it also prevents the emergence of resistant strains by using the combination therapy. All right, so what does trimethoprim do? Trimethoprim, it inhibits the activity of the dihydrofolate reductase, that enzyme that converts dihydrofolate to tetrahydrofolic acid. So this is actually an inhibitor of that enzyme. Okay. Again, it's used in the same, as I just said, it's used together with the sulfa drugs, so it's the same spectrum of activity, and it's used in combination with the sulfa drugs. Okay, I want to just take a couple minutes and talk about some of the antibiotics used for mycobacterial infections. Again, Dr. Fox pointed out, these bacteria grow very, very slowly, and so consequently, combinations of antibiotics are often used to treat these things. Another characteristic of these bacteria, if you remember, he talked to you about those mycolic acids that these organisms have. Those mycolic acids make these bacteria resistant to a lot of antibiotics simply because the antibiotic can't get in. So it's hard to get things in. So there are some antibiotics that that have been developed basically that get into these organisms a little better. All right? And so that's why they're used. And one of them is this para-aminosalicylic acid, or PSA. And the mode of action of these are essentially like the sulfa drugs. All right? They are competitive inhibitors of paraminobenzoic acid. Okay? And so they work just like the sulfa drugs do. And this one is particularly useful in treatment of Mycobacterium tuberculosis. So it's one that can be used in combination therapy for the treatment of these organisms. The other antibiotic is called dapsone, and again, it also is a mode of action similar to the sulfonamides. But the difference is that this one is used in leprosy. Okay, this one gets into the Mycobacterium leprae very well. So it can be one that can be used in the treatment of leprosy. All right, I think what I'm going to do, rather than going on to this, I'm going to stop here, and we'll pick up at this point tomorrow